Nancy.
Okay. I'm Nancy Lynn. It's closer. I'm a medical oncologist at Dana-Farber in Boston, and I specialize in the care of women with breast cancer and divide my time between caring for women with breast cancer of all stages and clinical research. So I also want to thank the BCRF and Evelyn and Peg and Cliff and many others who have contributed to this effort. Because as I'll share with you, there are three major areas that we've been working on with BCRF support with a very specific focus, and that is a specific complication of breast cancer when breast cancer spreads to the brain. And clearly, you know, hearing that is very hard for any woman to hear that kind of news, and it's something that worries people a lot. Fortunately, it's not a very common occurrence in women with early stage breast cancer. But in women who have stage 4 breast cancer, somewhere between 10 and 15% of all such women will develop this problem. And unfortunately, there are not very good treatments if a woman has already received radiation treatment to the brain. And even that, in and of itself, radiation to the brain, is a treatment that many women would prefer not to receive. So we've looked at this in three different ways with BCRF support. The first is that we've tried to identify the types of breast cancer that are most likely to spread to the brain, and beyond that, what are additional factors that might help predict which women may develop this problem and which women might be spared from this problem. And we started by looking at this question within the Dana-Farber population of women with a specific subtype of breast cancer, so-called triple-negative breast cancer. And we've since then leveraged the information that we gathered to actually look at this effort nationally in almost 13,000 women with breast cancer as part of something called the National Comprehensive Cancer Network. So we've actually been able to look at the patterns of where breast cancer might spread according to the different subtypes of breast cancer. And we hope that that information may help us better tailor the types of treatments we give to women to prevent specific types of breast cancer recurrence. The second effort has been in trying to develop new treatments for breast cancer that has spread to the brain, and we've led and completed 2 clinical trials in women with a different subtype of breast cancer, that is HER2-positive breast cancer. We have another study that's ongoing with BCRF support, and we have another study that's ongoing in a different subtype altogether. So, you know, 4 studies that have really been supported primarily through BCRF efforts, and another study which is a partnership with industry, but again would not have been possible without the initial seed support from the BCRF. And just to sort of expand on this theme, I think one of the really important things that we learned from this process is that when we first started this work, it was exceedingly difficult to get drug companies interested in this topic at all, because it's just not common enough. And it was really only because of BCRF support that we were able to launch the first of these very small studies. And since then, we've had a number of partnerships with pharma, and also in very recent months, the National Cancer Institute has recognized this as a problem, and we've been involved in some of the think tanks that they've put together. So, you know, there's really been a lot that's come out of this initial funding from the BCRF. And finally, we've been looking at ways to predict which patients might benefit from treatment versus which patients might not benefit. The traditional way of doing clinical trials or treating women with breast cancer is to give a treatment, do another set of scans after treatment, and see whether there has been a response to treatment. And usually those scans are 2 to 3 months down the road. And what we'd like to do is to be able to develop ways of knowing a week or 2 or 3 weeks later whether the treatments would be effective. Both to give peace of mind to those patients in whom it will be effective, and also be able to change treatment very much more quickly in women in whom it will not be effective.
Just great. Wonderful to hear. And so the theme there is that even if breast cancers look the same under the microscope, their behavior can actually be different, but it's different in predictable ways, and that's what is being leveraged here to tailor therapies, right?